My name is Rick Lewis. I'm in practice in Sacramento, California. Started practice in '84, and have been through the full spectrum of glaucoma surgery. And it wasn't until really the late '90s that I just got so disgusted with the complications of trabeculectomy that it was really incentivizing me to kind of look at other things. I want to start off with a little story, and I got to thank Gary Condon. Anybody know Gary Condon out there? He's a glaucoma specialist in Pittsburgh. This is actually his joke, but it's a good one. I think we can share it because it is dinner time. It has to do with our eating habits. You know, those from Thailand eat very little fat and suffer a few heart attacks. Certainly a lot fewer than the British or Americans. On the other hand, the French eat a lot of fat, and they also suffer fewer heart attacks than British or Americans. The Koreans, they drink very little red wine and suffer very few heart attacks compared to British and Americans. And the Italians, you know, God bless them, they drink excessive amounts of red wine, and they still suffer fewer heart attacks than the British. It just makes you, what's the message here? Well, you can eat and drink what you like. It's speaking English that kills you. So be careful tonight, because this will all be in English. But I like that story. So my background has always been one focused on glaucoma surgery. My very first publication fellowship was a randomized trial comparing trabeculectomy to thermosclerostomy. That was the old SHAPE procedure, a full thickness procedure, and we showed a large number of complications that have continued to be showed on the TRAB versus tube study up to the present. My most recent publication came out in the JCRS on canaloplasty with the 3-year results. And in between, I want to talk in this lecture about all of the above. Coming out of fellowship in the 1980s, the winners at that time was argon laser trabeculoplasty, peripheral iridotomy, viscoelastics, multiple Molteno implants, and 5FU. And the loser based on that study was the full thickness surgeries. And it's interesting as these trends have changed over the decades, because in the 1990s, SLT took over for ALT, the Barbelts took over for the Moltenos, and mitomycin took over for 5FU. As we had to get into the new century, we started getting introduced, especially me personally, into the canal non-penetrating suprachoroidal procedures and the express shunt, and the losers was the concern about trabeculectomy complications. And that's what led to that TRAB versus tube study and all of our concern that we continue to have in this introduction, this influx now of new glaucoma procedures. So as we head into 2012, we really have to think about this not unlike refractive cataract surgery was in 1982, in that we still have a ways to go in avoiding these complications. And so when we look at the TRAB versus tube study, and everyone in this room has heard this probably multiple times, this is sort of the cornerstone now of our glaucoma surgical piece, is, how do we successfully get pressure controlled without having complications? Because they showed in the TRAB versus tube study great long-term efficacy, even out to 3 years, pressures down in the low teens. But the probability of failure was dramatic, particularly in the trabeculectomy group, where by 3 years, 30% of the patients had failed. And in the tube group, even 15%. And whenever I looked at the TRAB versus tube data, I'd say, that was them, that's not me. My results are always better than theirs. My results, I don't have as many complications. But then when you look at your complications, it's shocking. It's amazing what we all have, even though we kind of bury them. We don't want to acknowledge the issues. In the TRAB versus tube study, the early postoperative complications, and I've summarized this into sort of the early and the late, but just look at that bottom line, because the total number of patients with early postoperative complications was 37% of 105 patients. And that's just unacceptable. In fact, I've often said in lectures that if trabeculectomy had to go through what canaloplasty went through in terms of getting FDA approval, trabeculectomy wouldn't. That this rate of complication the FDA would not allow it to go through. And it was obviously grandfathered in because we've been doing it for so long. If you look at long-term complications, at 3 years, now both procedures have up at over 30% relative complication rate. And these are good surgeons, good academic centers, well-trained glaucoma surgeons, and again, I think a very unacceptable rate of complication. If this was cataract surgery, we wouldn't be seeing people having cataracts. So And then if you finally look at the serious complications, the total number of patients with serious complications was close to 30%. And this includes reoperations and visual loss of greater than 2 lines of acuity. Unacceptable levels of complications. And it's these kinds of issues that drove me to do canaloplasty in the very beginning. And that's when I started talking to Mike and the iScience group about going on board. So, why has glaucoma been so slow to evolve? Well, we really have a poor understanding of the outflow system, as we heard in the AGS lectures this morning. Our classification system is askew. We need to be more refined and open versus closed. The practice patterns that we all adhere to are dominated by the pharmaceutical companies, and now that they're all generic, you're going to see a tremendous change, almost a 180-degree turn, because now the pharma companies, particularly Alcon, they own the Express, they're going to be pushing surgery. So that pharma-dominated practice pattern is going to change. It's already changing. We're seeing a number of new devices, and it's going to push all of us and patients towards early surgical options. But the most important thing was this lack of good surgical options, and it wasn't until these non-penetrating surgeries came on board that we now have some options for patients that get away from trabeculectomy. In fact, I have a lot of my patients who come to see me strictly for canaloplasty from all around the country come because they read about trabeculectomy and they read about canaloplasty and they say, I'd rather have that. I don't want to go through the risk of a trabeculectomy. So I got involved in 2001, and when Mike came up to Sacramento and I was doing a trabeculectomy, and I said, frankly, and I think I can quote, this is a barbaric procedure, and I still feel it is. When we're excising sclera like we do, and I still do it, I still feel we are so poorly sophisticated. At that time, iScience was developing an ultrasound to prove that the canal system was occluded, and that's what they showed. And in fact, I showed it, and I presented it at the AGS meeting in the early 2000s, that when you do ultrasound of a canal in a patient with open-angle glaucoma, the canal system has collapsed, and that's partly why the pressure's up. It's partly collapsed because the meshwork's defective, but the whole collector system is ultimately involved in this. That led to this development of the canaloplasty procedure. We didn't actually have that name in the beginning, but what we did do was develop a flexible 250 micron micro cannula, and this was in conjunction with Robert Stegman in South Africa. And Robert developed it because when you try to do trabeculectomy in black patients, they fail, and his patients were failing repeatedly. He needed a better way, and that led to the development of this, the viscocanalostomy and then ultimately canaloplasty. We then did a viscodilation of the canal in eye bank eyes. We presented that material here at the AGS meeting, and that led ultimately to the development of a canaloplasty procedure because we showed with viscodilation and the suture tensioning, we could actually get pressure lowering. So, and that's the canal that we're gonna show in our video here right now. So this is the video. This is actually Robert Stegman's video, and I just can't get a video as good as this. But what I want to point out to you is well, I'll show it to you in the next slide. But this is the catheter coming into the canal system. It's got that blinking red light, and it allows you to make sure that you're in the right location. Frankly, when this is happening in the OR, even now having done this for 4, 5, 6 years, everybody in my OR stops and watches the monitor. They're all impressed that we are in the canal, that this canal exists, and they can see it go around. It comes out the distal end. We then will attach a Prolene suture to it, either 9 or 10-0, and it isn't passing the canal that's challenging. The beginner's challenge is finding the canal and feeling comfortable with it. I think all of our levels of comfort finding the canal is much better now because the concept of canal procedures is clear, and that's the one thing I'm going to emphasize in my next video is identifying the structures that lead to the canal space. Anyway, we then attach this Prolene suture. In this case, it's a 10-0 Prolene attached to the distal end of the catheter. We tie it tight, and you got to be careful that you tie it tight because if you don't, as you're pulling the catheter out of the eye, the suture is left behind. So if you make sure that it's tight, and I actually pull on the suture, and the catheter goes with it. So once I know I'm well attached, I then remove it from the original insertion site, and we cut the suture close. And remember, as we're removing the catheter, we're dilating the canal system. We're injecting Helon GV to dilate the canal, and we show on ultrasound that preoperatively preoperatively we have a shrunken canal, postoperatively we have dilation. Here's a gonioscopic view of the suture in the canal, And that's an important landmark because in about 8 to 10% of patients, you may have to do goniopuncture. And that suture is the landmark. I want to go right anterior to that suture to do the goniopuncture. It doesn't come up a lot, but it is a nice landmark to have right there, and that's where you, and what your suture, what your sutures indicates is where the Decimase window is. Lastly, you're going to tie the flap tight. You don't want to have a bleb. Occasionally you do have a bleb, but that's really in the minority. So we don't want a bleb. We want to have a tight flap, and then we want to have none of the bleb complications that are so common with this procedure. So these are the landmarks that are so important to recognize. And this is the Decimase window. This is a very large window. In fact, this is a fairly posterior canal because the canal is right here. And people always say to me, how do you know you're in the canal? How do you find it? Well, it's these striations of sclera that identify where the canal is, and it's right here on this edge. And you can you just know you're there. And if you don't see those striations, you're not deep enough. The error of the beginning canaloplasty surgeon is they're too superficial. They don't go deep enough, and therefore they don't find the canal, and then they get frustrated. So in the beginning, when you're making your deep dissection here, it's better to err on the deep side. Even if you get close enough to the cellular body, you can always back off. If you don't go deep enough and you're shallow, you'll never find the canal. So you go deep here, and then you dissect this forward. You'll see this horizontally running striations, and the canal is right in front of it. And that works. It's a very, becomes very apparent to you when you're doing the surgery. So I want to talk about sort of my initial experiences, because the conversion from a level of comfort with trabeculectomy where you really can't do much wrong. I mean, I guess you could go too posterior and get the vitreous, or maybe you don't close your wound right, but it isn't like this where people in the OR are kind of watching you, kind of waiting to see the canal going through waiting for the catheter to go through the canal. So my initial fears was that, one, I couldn't find the canal, and those landmarks were critical for me to be able to understand my endpoint. The other concern was, you've got a busy surgical schedule, and maybe you're doing, I don't know, 10 or 15 or 20 cases, and you don't want to be tied up doing one procedure. And maybe someone's following you, and you feel this sort of pressure to get this done because maybe trabeculectomy maybe lasts you 20 or 30 minutes, and you're thinking, God, this could take me an hour. Well, in the beginning, it takes about 45 minutes or an hour. But as you get better, it's about 25 to 30 minutes. So I schedule it for 30 minutes, and that's what it takes me. It's a little longer with a combined procedure because of the additional phaco, but 30 minutes is what it takes me to do it. And, I'm comfortable with that. And frankly, the couple extra minutes that I spend doing canaloplasty, I more than make up post-operatively by the few complications. And those post-operative issues in trabeculectomy drive me crazy. Nothing's worse than doing surgery like I did on Monday and doing a trabeculectomy and then having to come to New York because something's going to happen. And it's just a question of, okay, my trabeculectomy patients, are they going to have a choroidal hemorrhage? Are they going to have a wound? Like, what's going to happen to these patients? With canaloplasty, I really don't have those concerns. I can do it. I did one Monday, felt great about it. Patient has done well. I saw her Tuesday morning, came to New York, and she's doing fine. So the initial fears about doing the surgery, you can certainly overcome with the trainers that they send to you and just getting comfortable in the canal space. The length of the procedure is manageable once you get over the learning curve, but the early outcomes was a big concern too. Am I going to get pressures equivalent to trabeculectomy? Can I feel comfortable that I'm doing the right thing for the patient? I don't want to put this patient through this if it's going to fail. We only have so many opportunities in glaucoma surgery. Well, the data, we published it. It's been peer-reviewed. We got 3 publications proving this. It's been done not just in the U.S., all over the world. Mostly a lot of surgeons in Germany, a lot of publications, and I'm going to show you the list of them, validating that this works both short and long term. So our 3-year data is, again, convincing evidence for me, and I hope for you that this works. So, currently we have done, as I said, about 350 procedures. It is a good source of referrals. For me, frankly, I'm the only one in Sacramento that's doing canaloplasty, and you find that there are patients who will seek you out if you're doing this surgery. They want the non-bleb procedures. So the issue then comes up is, when do you recommend it? What's the ideal patient? Well, it has to be an open angle glaucoma. You can't do closed angles, and you can't do some of the secondary glaucomas like a neovascular glaucoma. So it has to be an open angle. You have to do gonioscopy preoperatively to confirm that the angle is open. But there are certain patients who are better than others. The high myope, for example, who is at higher risk for a hypotony maculopathy, or the patient who's got ocular surface disease, in which you're really worried about a bleb either healing or scarring or getting infected. Great patient. African Americans, ideal patients because they're such high risk for having conjunctival scarring. Patients who are on blood thinners. We've got a lot of patients who are on Coumadin or aspirin or the newer blood thinner, and this is a great procedure for that. You don't have to worry about a choroidal hemorrhage. You might get a little bit of a hyphema. In fact, getting a hyphema in this setting is okay because it indicates you've got reflux and you're probably going to get a great result. But doing a trabeculectomy on a patient on Coumadin is a big risk. And any of us who've had choroidal hemorrhages, you just don't want to go through it a second time. So let's just point out again. I think this is actually Ike Ahmed's video. It's not quite well. Hopefully you can see it. But these are the striations that you're looking for here, and this is Decimae's window. So if we could run that video. So Ike uses a diamond blade, and that's why I show this, because I actually use a metal blade, a grease hopper blade. He uses a diamond. Ike's a tremendous surgeon, as you all know, and there's lots of ways of getting there. The key is not perforating, and he can do it with a diamond blade and get away with it, and that's terrific. Frankly, the big worry you have as a beginner is you're going to perforate. Well, if you perforate, you can always convert this to a trabeculectomy. You really haven't lost anything by doing this and converting it. And in reality, once you get qualified and trained, perforation is not a very common problem. So, excuse me. Let's see. So the indications, as I mentioned, open-angle glaucomas, especially the patients with pseudoexfoliation and pigmentary, those patients in whom you expect a trabeculectomy to fail, either because the other eye failed or because they had hypotony in the other eye, or those patients with significant conjunctival disease, and then the patients who are the high myopes, the contact lens wearers. This is a great example. A patient who wears contact lenses, they can't wear it with a bleb. Blebs increase the risk of infection. Canaloplasty is wonderful because they don't get a bleb. Patients who are immunosuppressed, and then those who are anticoagulated. Let me show our 3-year results, and I want to quickly kind of get up to the more recent publications. You can see that our 3-year results are very similar to the TRAV versus tube data, maybe a point higher, but close. In fact, our combination canaloplasty cataract is in the same ballpark of about 13 to 14 millimeters. We look at the safety summary, and there's no comparison to trabeculectomy. The big issue you have post-op canaloplasty is a small hyphema. That occurred in 13% of these patients. You tend to see in this group of patients the pressure is a little higher post-op and then gradually comes down, whereas with trabeculectomy it's often very low in the beginning and then kind of works its way back up. So that safety of having a pressure in the high teens the first couple days is actually relieving. It's helpful, not that that you're not in a hypotony range, but no evidence of bleb leaks or infections or choroidal effusions. The number of peer-reviewed publications is significant now, and this was a challenge in the beginning. It's actually more than 8, because there's 2 more that I read in the Journal of Glaucoma flying out to New York on this trip. So the peer-reviewed publications is well over 10. I think there's actually 11 peer-reviewed publications with data very similar to mine on the 1 and 3 year follow-up. One of the most interesting articles I thought was people always say to me, well, how does it compare to a trabeculectomy? Well, Ayala, who's in Tulane in New Orleans, did a comparison of surgical outcomes between canaloplasty and trabeculectomy at 12 months follow-up. And it's interesting because people say, well, it wasn't a prospective randomized comparison. But what he did, it was retrospective, but what he did was he took the insurance coverage as the way to randomize patients. So the patients who had coverage for canaloplasty in those days got canaloplasty, and those that he couldn't get coverage, they had trabeculectomy. So it's an interesting way to randomize patients, but it's another way. There's really no bias in the issue. He had 102 canaloplasty eyes in 87 patients. He had 156 trabeculectomy eyes in 112 patients, and then only 1 eye per patient was included in this analysis. Then he made sure that the canaloplasty flap was watertight so that he didn't get any bleb. He used mitomycin in the TRAB patients up to 60 seconds using a fornix-based closure. And then what he did was define failure as pressures greater than 18 with or without medications, or a pressure less than 4. Also, those that required a re-op or had greater than 2 lines of visual acuity. So keep this in mind as we show the results, because that's a pretty strict definition of failure. And here's his comparison, and you can see that the demographics of both groups was very similar. There's no statistical difference between both study groups. And you look at the number of medications at 12 months, and there's no significant difference. So the number of medications patients were taking was significantly less than pre-op, but no difference between the two groups. So people say, well, you know, I had to put a canaloplasty patient on drops, or that it failed. When I say, well, how often has your trabeculectomy failed, or how often has your Ahmed implant failed? Everything fails in glaucoma. It's a heterogeneous disease that we have a hard time defining. So don't take failure as an indication that the procedure fails. It's just part of the spectrum of disease. But going further on his analysis, the number of failed procedures was actually 15% in the canaloplasty group and 11% in the trabeculectomy group. So no significant difference between those two things. If we actually looked at his pressure results, you could see that preoperatively there were 21 in the canaloplasty group, 23 in the trabeculectomy group. These are patients that were not washed out, so it would probably be a lot higher if they were washed out. At 12 months, the pressures were down to 13 in canaloplasty, 11 in trabeculectomy, and I would take 13 every day with no complications if I could guarantee those results. Here's his IOP data. You can see it's well controlled, and then you can see what he did in terms of re-op. So the type of complications, though, was the big difference in this paper, in that the number of complications was significantly higher in the trabeculectomy group compared to canaloplasty. If you look down at the bleb revision or hypotony or suprachoroidal hemorrhage, the serious complications didn't happen with canaloplasty. So very convincing evidence. It wasn't my data. I thought it was important to share it with you because I think you'd probably say I'm biased. Here's someone else who did it. What about filtering blebs? Do they occur? Well, they can occur, but they're pretty rare, and that was another publication that came out of the Journal of Glaucoma. So, you know, there's been the 3-year data that came out of Europe, which is very similar to mine, demonstrated significant and sustained IOP reductions. But in summary, the key here is that the trab complications are post-op, that's early post-op and lifelong. Canaloplasty complications are perioperative. The issues that we worry about with canaloplasty have to do with the procedure, and you can be trained through those, so you can avoid those kinds of problems. Canaloplasty can compete with trabeculectomy. A number of studies, not just mine, have shown that now, that this is a very good and effective procedure, and it's for both early, moderate, and late disease. It's not just limited to the early types of glaucoma. So the last issue is learning curve, and I think that we have 2 relative novices who have adopted the technology to kind of share with us how they've gone through this learning curve, and then I think we can all have a panel discussion and discuss it more.